Welcome to the Allergy Asthma Network's 2016 webinar series titled Advances in Allergy and Asthma. I'm Sally Schessler, the network's Director of Education. It's my pleasure to welcome you today to the first webinar in this year's series. We will be exploring different topics each month with nationally respected experts speaking to you about timely issues and concerns. Please plan to join us each month. For our March webinar, it is my pleasure to welcome Dr. Randall Brown, a member of the network's board of directors. Dr. Brown is Director for Asthma and COPD programs at the University of Michigan's Center for Managing Chronic Disease, and for over 10 years has maintained professorships in health behavior and health education at the University School of Public Health. Dr. Brown received a BA and MD degrees from the University of Michigan and received his Master of Public Health degree from Harvard University. He conducted a pediatrics residency at Boston University and clinical fellowship in pediatric pulmonology at the Children's Hospital in Boston and Harvard Medical School. He also completed a respiratory epidemiology research fellowship at Harvard's Channing Laboratory. Dr. Brown has received medical board certification in both general pediatrics and pediatric pulmonology. Dr. Brown is principal investigator for 3 large asthma research grants that explore the translation of effective asthma educational models at all levels of clinical practice and how they affect individuals and families at risk. Hang on just one second. Okay, thank you. Having previously served as research director for the largest clinical pediatric pulmonology practice in the U.S., he is extensively published in allergy, ENT, pulmonology, family medicine, pediatric and public health journals, and received numerous clinical and teaching honors, including the inaugural 2007 AAOA Fellowship Award for Novel Asthma Education. Notably, his first authored work in JACI represents the largest study of asthma therapeutics among African Americans ever conducted. Dr. Brown is a member of the First International Respiratory Effectiveness Group, a panel devoted to incorporating rigorous understanding of adherence and other real-world measures into the science of evidence-based decision models for asthma and COPD. The award-winning asthma education program for medical professionals, PACE, of which Dr. Brown is director and co-author, is accepted nationally and internationally by numerous asthma and COPD projects as the model for clinician respiratory education efforts. PACE is highlighted on the National Institutes of Health asthma website. Lastly, as one of the few U.S. pulmonologists also recognized as a nationally certified asthma educator, Dr. Brown serves on the board of directors of the National Asthma Educator Certification Board, and he joined our board at the Allergy and Asthma Network this year. Dr. Brown, you're a busy man. We're so glad that you've taken the time to be here with us today.
Hi, Sally. It's a delight to be here. Thank you very much. I know it's 4 o'clock on the East Coast, 1 o'clock on the West Coast. To everyone, welcome. I'm delighted and honored to have the opportunity to speak to you on behalf of the Allergy and Asthma Network. Sally does a fabulous job. She coordinates education. She is noted in her own regard for the work that she's done. The network is a special organization, as many of you already know. Today's conversation will be about asthma essentials in primary care, also in specialty care. Specifically, we're going to talk about what I like to title inhaler hysteria or inhaler confusion and what to do. My appointment is here at the University of Michigan, and it is an appointment with the Center for Managing Chronic Disease. And we're delighted to be able to present and have this discussion with you today. So overall, when we talk about asthma educational objectives, much of this you already know about. We want to advance our understanding briefly of the epidemiology of the disease in the United States. We want to have increased learning about pathophysiology, some of the diagnostic tools, including spirometry. We want to enhance our familiarity with some of the inhaled therapeutic options and delivery systems for the various medications used to treat the components of asthma disease. We want to increase our ability to apply recommended treatment strategies into patient care, and we want to improve this disease that is every bit one of communication as it is inflammation. We want to improve our ability to enhance and implement effective strategies so that we can help our patients and families adhere with recommended treatment regimens. So that's me. We've already talked about my background. As far as outside disclosures and full transparent disclosures, I am an honorary fellow of the AAOA and the Board of Directors, as was already mentioned, of the Allergy and Asthma Network and the National Asthma Educator Certification Board. I'm an advisor on the pharmaceutical side for Teva and Spirometrics, and a speaker for various organizations, including the network, National Jewish Health, AstraZeneca, Meta, and Teva, and have research grants from the NIH and the JPB Foundation. So when we talk about asthma, we know that this disease, as mentioned, just as rheumatoid arthritis is an inflammatory condition of bone and joint, asthma is inflammation, inflammation, inflammation of the airways, which begets a whole lot of dastardly stuff. It begets airflow obstruction. That makes it harder to breathe. It begets, of course, bronchospasm, constriction of the airways. That makes it harder to breathe. Our airways are more twitchy or irritable, or what we call bronchial hyperresponsive. So that too, in response to various triggers, my trigger is different than yours, is different than the next person, is different than the next person, but that too makes it harder to breathe. And then, of course, all of this begets the symptoms that we know, which are cough, wheeze, chest tightness, and shortness of breath. Some of them or all of them. And of course, all of that takes place within the bronchial tree that we know so well, mostly in smaller than larger airways, but there are differences from person to person. So the impact is great. We have symptoms, we have airway obstruction, we have twitchiness, and we can have even changes that occur in the infrastructure of the lungs themselves, but it's airway inflammation that's the key. Now, some folks do have a innate vulnerability. You have some individuals who are triggered by someone who is smoking 1 block away, whereas others may themselves smoke 4 packs a day and aren't triggered. We have those who are genetically predisposed. We know that literature tells us that families, this can run in families, but it doesn't have to. That goes along with the whole atopy or allergy story, and there are environmental triggers that play a role. Again, just to remind you, lifting all boats, we want everyone on board here. While there are many environmental triggers, not everyone has the same trigger. For example, whenever there's a gym, one of the recreation buildings on the campus of the University of Michigan here, called the Old Intramural Building. It's called old for a reason, probably built in 1817 when the university was established. Whenever I do anything aerobic in that building, because of the dust, because of the mold, because of my exercise, I cough and I wheeze. But I could be, say, in my office here with 200 cats, all of whom smoke, and not have one problem. It depends on person, each asthma patient may be different. There's personality to asthma. One size doesn't fit all, but for the most part, inflammation here is the key, despite the phenotypic variance from individual to individual or in any given individual over time. Clinical symptoms, some wheeze, some don't. Some cough, some don't. Some do both. They can vary from individual to individual, and they can vary over time. And please remember that this is an illness that is not uncommon. We recall in 1980 we were concerned. By the end of that decade, we had our first iteration of national guidelines to treat asthma, but in 1980, with a prevalence of 3% of the population, we said, oh my goodness, 7 million folks with asthma? Well, we look at the 2013 numbers and we know we don't have 7 million folks in the United States with asthma. We have some 27 million folks with asthma, and the national prevalence approaches 9%, not 3%. Some neighborhoods, it's significantly, even double the 9% national prevalence. So this illness is a major public health concern. Having an understanding of its basic elements is sort of what we've done already today. And what I'll review for you briefly is some of the strategies that we've utilized to treat asthma. First strategy is one of a complete disconnect. And many of you have seen this data from the Asthma Insight and Management Survey, which was released in 2009. So a lot of folks think they're doing just fine from a patient perspective. No, some 71% of individuals in the United States who have asthma think that they're either completely controlled or well controlled with their asthma. No problem, right? Wrong. We know that when we actually drill down on what asthma is, we actually put a microscope and actually apply the correct questions, we find that 71% of individuals are not well controlled or even very poorly controlled. So this is a concern, especially in a disease that is so prevalent. Recall that asthma, if you're under the age of 18, is the leading cause of hospitalization. Recall that asthma is the most common chronic disease of childhood. But don't forget that this is not just a disease of childhood. It can affect the elderly, the young, and everyone in between. So we're going to spend just a few minutes, because that's not the thrust of the conversation I want to have today, but without reviewing where we are with this, without, again, lifting all boats, then I don't think we're doing service to the conversation that we're about to have. So we typically classify asthma severity on the basis of symptoms and impairment and even risk. So we look at the numbers, and these are national Heart, Lung, and Blood Institute, NIH, National Asthma Education Expert Panel guidelines that have been out now for quite some time, some 8 years. They'll change in the next 1 to 2 years, but for now, this is what we've got. We look at symptoms, we look at nighttime awakenings, we look at the amount of short-acting beta agonist use for rescue. What I like to call fire extinguisher use. If you use a fire extinguisher frequently in your house, my hunch is, despite your success in treating 5, 6, 20, 50 fires in any given year, my hunch is you would look for what the problem is. Yet in the United States, oftentimes that's all our patients and families utilize is short-acting beta agonist use. It's important to have a fire extinguisher. Let's not forget that. But the regular use of such probably indicates that there's a greater problem. Look at interference with activity, lung function if it's available to us, and then we also look at what someone's risk is to define how severe their asthma may be. How often are they having exacerbations? How often are they requiring oral corticosteroids? All of this goes into the mix in terms of defining what someone's asthma severity actually is. And by the way, this particular graph is those over 12 years of age and older. We, of course, have graphs that are for younger individuals as well. So the bottom line is to try to determine if someone has intermittent asthma, the mildest of the mild, or if they have persistent disease, symptoms more than twice weekly, or use of their albuterol more than twice weekly, or more frequent sleep disruption, or altered exercise tolerance. If so, then gosh, aside from the PRN use of fire extinguisher or the most popular short-acting beta agonist, albuterol, then let's consider some sort of controller approach. That led us, of course, in our national guidelines to medication recommendations. And I'm not going to talk about any one medication per se. I'm going to talk about some of the concerns that we have with medications as a group. But I think singling out one medicine over another is not where we want to go. That said, the national guidelines do give us a clear indication as to how we might want to approach therapy for persistent disease. Certainly the cornerstone of therapy in the United States and around the globe is the use of inhaled corticosteroids at almost every step except for the mildest of the mild, as we talked about before. There are other options as well, and sometimes inhaled corticosteroids can be given in combination with other medications. Clearly, we must consider comorbidities, and we must remember, for example, that someone who has allergies, somebody who has significant, say, allergic rhinitis, this can affect their asthma significantly as well, and if we can control one, then the other can be greatly enhanced. Long story short, summed up, if there's a fire on the 5th floor, the 3rd floor probably is going to be affected as well, taking care of both very common issues. Remember, we have over 50 million folks with allergies and asthma in the United States today. And so this is a pressing concern, and these guidelines help us. They also help us to remember that patient education and environmental control at each step are very important. So speaking of control, how might we assess this control? Well, we have these reflux-inducing charts again that sort of give us the classification schemes. Again, dividing the components of control into impairment and risk, very similar to what we saw with severity. These guidelines are available for free and have been out for the last 8 years. I won't get into them except to share that oftentimes while spirometry and pulmonary function testing can be extremely helpful, there are many offices across the United States that unfortunately either don't utilize that technology regularly because it hasn't been woven well into the workflow of their practices, or because the tests are challenging to do. Even for those practices and for practices that do utilize spirometry, utilization of very simple to use validated questionnaires can be quite helpful. If you ask someone with asthma, how's your breathing? They may say, oh, it's just fine, even when they needed to use their albuterol 3 nights ago 30 times. That's because 2 nights ago they only had to use it 20 times. Last night, while chasing their dog, who didn't smoke, they sprained their ankle. They may be in your primary care practice. Today, chief complaint, my ankle hurts. But because they only had to utilize their albuterol maybe last night 5 times, compared to the 30 times from 3 nights ago, they may say, I'm just fine. It's much akin to what we see with diabetes. Someone may say that they're fine, but that doesn't stop us from obtaining a hemoglobin A1C. If we saw that their blood sugar was 500, if we saw that their hemoglobin A1C was astronomical, we would do something about it despite the fact that they say, I'm feeling okay. So utilization of validated questionnaires through which one can apply a number similar to hemoglobin A1C, the utilization of validated questionnaires which take all of 90 seconds to acquire the information in English or in Spanish can be very helpful even in the busiest of practices. Here's an example of one such asthma control test. The scores there for each question are on the right, totaling in this patient someone who is well controlled, someone who is at 20 or above is well controlled, and this particular individual answering 5 simple questions within 90 seconds or less. And by the way, recall that in clinical practice, if you really want something to get done in anybody's clinical practice, for heaven's sakes, don't give the task to the doctor. Give the task to those who can routinize whatever test it is or procedure it is that needs to get done. If you want weight measured, if you want blood pressure taken, then make sure those who are checking in the patient know how to do this. Make sure that they know how to do an ACT so that when the doctor, the nurse practitioner, the physician assistant walks into the room, then the score is already there. Very helpful. Asthma control test, free of charge. Also uploadable on almost every EMR system in the United States today. So in order to determine if your patient is controlled or not, we, again, look at symptoms, we look at use of albuterol, we look at sleep exercise tolerance, and then if necessary and if available, we also want to look at lung function as well. And then we adjust our therapy based upon whether or not someone's controlled or not. So we can increase, go up by 1. If they're doing well, we can go down by 1 in terms of the step in their therapy as recommended by the national guidelines. Here again is that stepwise approach. So if someone was at step 4 or at step 3 and they clearly were doing well over a course of a number of months, then I would drop them down to say step 2 and see how they do. I would take into account what their environmental control is like in their season of concern. I may not drop them. If they're highly allergic, say, to ragweed, then guess what? In the Midwest, then you know, in late July, in August, early September, I wouldn't necessarily drop them even if they were doing well. But if they're out of ragweed season, then maybe that's something that I would do. That is an approach that has been recommended by the National Institutes of Health, and it's a fairly sound one. We have examples of good sort of plans of action and not so good plans of action. This one is a little bit busy, in part because it's shrunken down to fit into the slide, but it gives you a one-page sort of green, yellow, red guide as to where we want to be with our action plans, how we can individualize our action plans. Very helpful for folks. Keep it simple is the bottom line with action plans. Now, I mentioned earlier that this illness, asthma, in 2016 as it was in 2015 and before, is every bit as much a disease of inflammation and communication. We know that communication issues, and we've been studying this here at the University of Michigan over the last 15 to 20 years, we know that how we talk to our patients and what we say and how we share information, not far beyond how much information we share, does matter. A little bit more about that, but I did want you to know that a lot of this comes from work that we've done with the PACE project, Physician Asthma Care Education Project, which also has evolved into the Nurses Asthma Care Education Project, which has then evolved into the Australian PACE project and the UK PACE project. So it's been validated and looked at all over the world, and its premise is one that we now, from a behavioral perspective, agree upon across the United States from an asthma therapeutic standpoint. And I'll definitely delve more deeply into this topic as we go forward today. So every single one of us who is on this call today, we know that one of the biggest challenges that we face in asthma care or in the care of any patient with chronic illness is adherence. And if you ask a patient, are you taking your medicines, we know that they typically, even when they're not, they typically will say, yes, I am. Sometimes families feel like they're wasting a clinician's valuable time. They feel as if the clinician, they feel as if you expect perfection from them. I mean, after all, there are a lot of people wearing these uniforms and scrubs, and it's antiseptic, the location where you're evaluating them. The rooms are clean and tidy. We are all dressed up, and the feeling is that, gosh, you're taking time, you're spending time. Dr. Brown, you're expecting me to be perfect. In fact, that's the worst message that we could possibly convey if we wanted anyone to be adherent with a medical regimen. If they feel, we think, that they need to be perfect, and if they're looking at us as a model of perfection, then again, they feel as if they're wasting our extremely valuable time. They may omit details that they deem unimportant because they don't want to waste your time. They may be too embarrassed to mention things that they think would make them look bad because, gosh, the last thing that they want to do is to admit that there is a wrong. And maybe they don't understand medical terms, but they will nod their head and say, yes, I understand, too embarrassed to admit that they don't understand. Many folks also believe that their clinician hasn't really listened to them, and therefore, at the end of the day, doesn't have the right information needed to make a good decision, and so therefore, once I get out of this office, well, I'm going to do what I want to do anyway. I just wanted to make sure that I wasn't going to die today. Many believe that their clinician doesn't understand them, doesn't understand their walk of life, doesn't understand their social or their cultural experience. This stuff happens all the time. And then lastly, I want to say this. If you have a patient who is taking their medicine on a regular basis, and they swear up and down that they're taking their medicine on a regular basis. By the way, they're also the patients that brings you in the holiday cookies. They remember your birthday. They take their medicine. They refill their medicine. I suggest, half-heartedly, tongue-in-cheek, I should say, that maybe you should work that patient up for obsessive-compulsive disorder at the same time. The point here is that non-adherence is normal. It is abnormal to be fully adherent or to use the word of compliant. And the ways in which we can effectively communicate with our patients actually breaks this down. One of the kindest things that we can say to a patient is, you know, Mrs. Jones, you know, Mr. Johnson, that, gosh, most of my patients will remember to take medication X instead of weekly as prescribed. They'll, you know, or once a day as prescribed, they'll remember to take it once a week or twice a week. How often, then I ask, how often do you take the medicine? And they'll say, well, I'm a little bit better than average, Dr. Brown. I take it 3 times a week. The point being, that's a heck of a lot closer to the truth. And by phrasing the question in this way, essentially what I'm saying is that we know that adherence is an issue. We know that cost of medications is an issue. We know that sometimes devices are not what they should be in terms of how they're explained, how to use them. We know that folks have worries, have concerns, and Therefore, adherence isn't perfect, and the health behavioral and health education literature is filled with reams and reams of data about how non-adherence is normal. And so our charge is to approach this adherence issue from a perspective of understanding where most of our patients actually live. So what I want to do now is stop the lecturing and actually give you a case. And I think we learn a lot by cases. So we have family practice folks on the line. We got pulmonologists, we got allergists, we've got otolaryngologists. We've got all folks from all walks of clinical life. We have respiratory therapists, docs, nurses, medical assistants, health educators. We got the whole gambit who's joined us today. But this is not an atypical case. You're meeting a relatively young woman of Northern European heritage with a long history of what she calls recurrent bronchitis, who was recently seen in urgent care due to a severe cough. She's relatively new to you. Maybe you saw her once for a former partner of yours, and now you're seeing her again. She was given a prescription for albuterol, and she's taking it 4 times a day, and she's improving on her oral steroid therapy. And by the way, in urgent care, they threw in a course of azithromycin as well. So you examine her. Chest is clear. She's talking to you. She's not in any distress. Her history is remarkable for lots of emergency room visits, all of which resolve with the machine breathing treatments. She states that usually when she doesn't have the machine, things don't work for her. She's needing her albuterol puffer twice daily at least. She can take it up to 4 times a day, but she uses that every day when she's healthy. And yeah, she smokes a little bit, she says, but who doesn't? So, of course, this being an asthma lecture, we're going to jump to the conclusion that asthma is known by a lot of different names. Reactive airways disease, recurrent bronchitis, we call it all kinds of things. My favorite is the TOP syndrome. Doc, I just have another touch of pneumonia. But when someone is responding to albuterol and responding to a steroid course, then it's highly likely from an epidemiologic consideration that this could be asthma. She also, with pulmonary function testing, you would want to see when you do improve her, if she returns to normal. If she returns to normal, then gosh, her pulmonary function testing would suggest with normal PFTs when she's absolutely healthy that she doesn't have chronic obstructive pulmonary disease. The question is, so what management plan do you choose now and why do you choose it? Then you decide to do this.
Are you ready for your video, Dr. Brown?
Let it roll, Sally.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes.
Oops.
Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So clearly, what we have here is a case of someone who hasn't had the opportunity to get better, who notices that the machine, when she's in urgent care, works so much better because her technique isn't what it should be. You may not have been able to hear commentary so well, but you could see the pictures as to what was going on there with Dr. House and his patient. This patient was utilizing the Chanel No. 5 or Old Spice technique of delivering medicine to her airways, and I can safely say that she wasn't getting very much. It's no wonder that this aspect of her care, the adherence to her medication, namely an inhaler, has caused her to have problems. When we take a glance at the Allergy and Asthma Network's respiratory inhaler at a glance poster. By the way, this is available to each and every one of you, and I believe that every single office in the United States should have one of these posters. Why? Because rarely is it happening in the United States when folks refer to their medication by name, brand X, a generic brand Y. They say, I'm on the blue one, I'm on the red one, I'm on the green one. Often is the case where maybe they're not taking the medication correctly, as you saw with Anna, but it also could be the case that they're taking the wrong medication. They're borrowing Cousin Louie's or Aunt Josephine's medication, and they actually have the, because there are 4 or 5 or 6 reddish looking ones, they have them mixed up. This happens frequently, and so it's important to have a non-branded pictorial display of all of the inhalers that are available, because over the years folks get confused. Inhaler confusion rules the day in the United States, and by the way, that inhaler confusion is not limited at all to just our patients and our families, nor is it limited to just respiratory medications for asthma and COPD and bronchospasm. We also have a whole bunch of nasal inhaler nonsense where we have a lot of different devices, right? The concern, though, is more in this particular lecture, is more about the inhaled medications. And if I might, just for a minute, digress and say that this issue, once again, is not just for an issue of confusion for your patients. We as clinicians in the United States, and these studies, Dr. Dorshug, most notably, out of the University of Iowa, has conducted these studies where we look at how well or how confused we as doctors in the United States, we as practices in the United States are about these medications. It's quite concerning. We don't score very well if you look critically at the studies as to how well we can actually demonstrate. Each and every one of us can demonstrate one of these devices. We don't score well on the examination. There are some 30 different inhalers available in the United States right now. Some of them you twist, some of them you click, some of them you push, some of them have been advertised as being progressive in the recent inhaler design since the last iteration of guidelines in the last 8 years. Some of them proudly tout that they're warm, or that they're cool, or that they're slow, or that they're fast, that they have particles that are small, that they have particles that are large. Again, you push, you pull, you inhale, you exhale. You put the left foot up, you put the right foot up, you spin around. So is it any wonder that all of us are confused? And by the way, for those of you who are writing prescriptions, please remember that some of us are relying on this information to this education on how to use a particular we've done the work, right? We've made the diagnosis. We see that the medicine needs to be delivered, right? And maybe not every office has a certified asthma educator, and we don't have all the tools, nor do we have the time. We often say this, and so we rely perhaps on folks. Okay, make sure you get to the pharmacy, pick this up, and the pharmacist will deliver that instruction. Well, guess what? The pharmacists don't have time, and our patients and families oftentimes don't either. They'll check the little box that say, oh, of course, an inhaler, I know how to use it. But then when they get home, it's confusion. In what way are they confused? In what way are we confused? This is not just them. This is all of us in the United States who are confused about these different devices. Let's take a look at some of the data. So the overriding issue here is that inhaler misuse is common. We have studies that point to the fact that of all of those folks who've been treated with an inhaled steroid or a short-acting beta agonist, SABA, and this is not limited to just the United States. This is around the world. Of all of these folks, it's only 29% actually use the medicine correctly. Now, some are worse than others. One of the Journal of Asthma studies suggested that 3% of individuals in the thousands of patients in this particular study, 3% of individuals forgot to take the cap off. We know that folks breathe into their device when they're supposed to inhale. We know that folks are poorly coordinated with their device. We know that folks are not clear as to the best ways in which to use these devices, and that's assuming that the prescription gets filled in the first place. So this, too, adds to this whole adherence conversation. And gosh, we want the medicine to go where the medicine should go. We've done all of this. They've done all of this work. They've come in to see you. Let's try to get the medicine to where it belongs. How can we help them know what to do? How can we help our own staff understand? What kind of in-service can we deliver to our staff? Remember, respiratory illness. We're talking, inhaler use. When you combine the 50 million folks who have asthma and allergies, who are using some form of inhaled medication, either mostly to the lungs, but some to the nose as well. But when you combine them with the 15 million who have COPD, you're up to 65 million. You add another 15 million who have some form of non-specified chronic respiratory complaint for which they're using an inhaler. We're talking some 80, 90 million folks where we have 71% of them not using the darn thing correctly. So clearly this is a public health concern. It cannot all be on, when you have a problem that is this prevalent, it can't just be them. It's us too. So there have been studies that have looked at what the outcomes are from misusing. We know, for example, that asthma is under poorer control. Asthma is more unstable when folks are misusers versus good users. Folks are poorly coordinated and misusers. We know that there are likelihoods that folks are going to visit emergency departments, even have hospitalizations and seek outpatient care if they have medication choices or medication delivery that is suboptimal. And so what can we do? What can we do? For example, Mrs. Jones is an African-American grandmother who sees you. Her 17-year-old grandchild, Charles, is also coming in to see you now for the first time. So Charles, and this could have been me, when I was 17. Charles has a history of numerous asthma hospitalizations and emergency department visits over the past year, and you find that he uses his medication faithfully as prescribed by his prior physician. He even uses a spacer with his combination medicine. His grandmother has switched to you as his doctor because Charles has been in such poor health over the past year, and she says she's recently learned that one of the components of Charles's daily medicines can cause death. And maybe that's what's going on, especially in African Americans, or as she says, in black folks. You find out, if we can switch to the next slide, that she too has inhaler confusion. What she was doing had nothing to do with the components of the medication. What she was doing, as she was prescribed for Charles, but as she was confused about for Charles, she was actually taking one of the dry powdered inhalers and putting it into a spacer device. And she just got mixed messages. So how can we avoid? Sure, these are dramatic examples of Chanel No. 5 technique, Old Spice technique, putting a dry powder inhaler into a spacer. You're not going to get any medicine into the lung any of these ways. But short of that, we have folks who also are struggling with their technique. What can we do? Not in a fancy office that has all the bells and whistles, but what can we do from a public health perspective in most offices in the United States? By the way, some 70 to 80% of asthma patients are not seen in the specialist's office, in an allergist's or pulmonologist's office. They're seen in primary care. So what can we do in most offices, most clinical spaces? How can we health educate better in the United States around all of this? Every office must have. So because we have these 30 different devices, the first thing you need to know is that every inhaled medication has its own product website with a video training. So brand X, brand Y, brand Z may differ, but please know that each of these medicines, whatever is chosen, has a website that can reinforce for you, for families, how to use that medication. That's something that you need to know. A picture is worth 1,000 words. A video, 30-second, 60-second, 90-second video clip is certainly worth 10,000 words. There are outstanding free sites, free video sites, free YouTube sites. Now, you can't trust everything, of course, that we see on YouTube. We don't want to get some guy in his basement on the outskirts of Lansing, Michigan, trying to tell us how to treat their asthma. By the way, Lansing is the home of Michigan State, the University of Michigan's arch rival. I couldn't not, especially because my brother went to Michigan State, I couldn't help but to get in a little big there. But we know that we have great free sites, for example, from National Jewish Health on YouTube. This website and the collection, this particular address that you have right here, is a collection of 29 clips with various medications in English and in Spanish. You can have the education there even if you don't send your patients home with these clips, which I've done before. You can have this available, say, on a computer in the office, so you can actually show folks really easily how to use the medication that they're given. These are free sites, and they can be very helpful. There are paid websites with free stuff on them. For example, the useinhalers.com site is in part paid, but has free stuff. There are clips on how to use the various medications, almost every inhaled medication, in 12 different languages. So it's multilingual, it's accessible, it's got free stuff on it. This is extraordinarily useful stuff to have. And as I suggest here, a video may be worth not just 10,000 words, but a video may be worth 10,000 exacerbations saved. And then last, but certainly not least, as I already mentioned, take a look, and a must for every office is the Allergy and Asthma Network's poster, which, by the way, is not a poster that contains medicines from 8 years ago. This is a continuously updated poster, so even the newest medications as of a few months ago are on the chart, and the next iteration will have updated medicines. We are, in this year alone, going to have at least 3 or 4 newly released inhalers by the time December 2016 rolls around. So, in summary, what we need to remind ourselves is that this is a very common condition. That this disease, yes, is inflammation of small airways of the branches of the tree, and we know that this chronic condition causes a lot of problems in the United States. The leading cause of school absence, over 100 million job days missed every single year. But asthma is also a disease of communication and of culture, and it preys upon our practice as usual. And unless we strategize around more effective communication, not quantitatively more, but better qualitative communication around this illness, then we are going to be subject to repeating the errors that we've made in the past. Proper inhaler education or proper inhaler use is not a given. And when we close the door and look at the mirror, each and every one of us can say that, we may not understand as well as we should how one should actually use these devices. So we should have folks demonstrate their technique. Certainly, bring your medicines with you so you can demonstrate the technique. Maybe we'll see what Dr. House saw. Achieving good asthma control with proper medication use is certainly important to reducing exacerbations and improving quality of life and gaining better outcomes. I want to thank you for giving me the opportunity to address this concern and talk with you today. Please do visit the Allergy and Asthma Network for helpful tools. Thanks much, folks, and I look forward to engaging any questions that you may have. Sally?
Well, Dr. Brown, we are so grateful that you could be with us today. I got to tell you, I was chuckling through so many. I was afraid I was going to laugh out loud at times with, I like the cats who smoke in the office. And I especially liked your fire extinguisher story, because I think so often we think about the medication as just, the tool to help the issues. But then we have to remember that sometimes we have to solve the underlying issue so that the medications aren't being used so often. So I really appreciated a lot of the things you had to say today. We've only had one question, and I will pose that to you. Someone wrote, as a school nurse, I often have to ask a parent to call the doctor to have their child seen. What can I do if they think that they are well controlled, but according to the NAEPP control classification, they are not?
Well, thank you very much for asking that question. And Sally, by the way, you know that how we communicate, how we make clear to folks what's actually going on is the art of medicine. And the terminology that I've used today, I encourage folks to use it, abuse it, do what they want with it. We are storytellers, and if what you've heard today you can use as a tool in your care of your patients, then please do so. That's how I learn, and hopefully others can gain from that. So in answer to the question from the school nurse, this is very common, where folks are so used to having problems that they just think that it's normal.
Oh, yes.
The last thing that any parent wants, myself included, is to think that your child may be sick, and if what you're seeing is normative for them, then there may be a significant bit of denial that's happening. But I think what's helpful in this particular regard is to share with them what asthma control actually looks like. Many folks think asthma control is staying out of the hospital and everything's fine. So yes, the school nurse is calling, but the child may not be in the hospital. They only have to go see the doctor yet again. They only need maybe the 3rd or 4th or 5th or 10th asthma treatment this week in the school. So everything's fine because they didn't have to visit the emergency room or hospital this week. But when we share with folks what control looks like, when we share with folks that, you know, you can have severe asthma in the United States, but it can be well controlled. You can have severe asthma in the United States, but it's well controlled to the extent that you don't need your fire. You don't need your albuterol more than once, maybe more than twice a week. You certainly don't have problems with your breathing more than a couple of times a week. You're certainly not requiring not only fire extinguisher, but fire hydrant therapy in the form of oral steroids. You are active. It's more important, is the public health argument. It's more important for the asthma patient to be physically active. You know, 18% of the 2012 Olympic team has asthma. Why can't, and by the way, that asthma is well controlled, why can't my son or my daughter, why can't your patients also have control in that regard, where they're as active as they want to be? They're not missing out on sports. They're not used to sitting out because they're having respiratory complaint. So giving them an example of what good asthma control looks like, fully active, sleeping through the night without the need for frequent or even infrequent albuterol use, and rare need for rescue. It's those kinds of examples that can help folks understand where they need to be.
Well, thank you so much today, Dr. Brown. You clarified some information that is often very confusing. I'd like to encourage everyone to be sure and register and join us for the remaining webinars in our series. The next one is April 27th at 4:00 p.m. Eastern Time. Please join us to talk about what happens when patients struggle with being in the yellow zone. As always, the mission of the Allergy and Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. And before we part ways today, please access the Allergy and Asthma Network's website at allergyasthmanetwork.org for valuable information with sections designed for patients and healthcare professionals. And finally, there are 2 great events coming up soon. Please check our website for information and registration for our Allergy and Asthma Day on Capitol Hill on May 12th. Learn about important initiatives and make a difference by visiting your legislators. And watch for information about our U.S. Anaphylaxis Summits in September. We'll be presenting these in Las Vegas, Nevada, St. Louis, Missouri, and Orlando, Florida. Yes, that will be at Disney World. This is Sally Schessler, Director of Education, and on behalf of the Allergy and Asthma Network, thanks for joining us today.